Hello, my name is Dr. Alvin Florentino, current president of the Society of Pediatric Critical Care Medicine Philippines, and my talk will be on Challenges of the Past, the Asian PICU story.
They say children have special needs, and this is particularly so for children who require the most specialized care that only pediatric ICUs can provide. Despite the late development of the pediatric ICU in Asia, it has conquered the challenges and overcome difficulties and come out as one of the most significant contributors to pediatric healthcare in the region.
Along with the explosion of understanding of the nature and demands of the critically ill, the development of the necessary technology, pharmacology, and other aligned systems paved the way for growth and advances in anesthesiology, which later on expanded into the critical care arena. Although developments in adult critical care eventually fueled the extension into the pediatric population, pediatric critical care medicine in low middle income countries is still today mostly in its infancy. Issues regarding lack of dedicated PICUs, adequately trained healthcare staff, access to medications and equipment are still of paramount consideration. In addition, the absence of pediatric critical care training programs limit those who are properly trained to manage the units, with most hospitals still relying on general pediatricians, pulmonologists, and cardiologists to supplant the need for personnel coverage. All of these will naturally require close coordination and financial support from hospital administration and quite possibly even the national government to oversee assistance in terms of laws and guidelines. More importantly, at least in low middle income countries, financial capacity influences parents' decisions on whether or not to bring their critically ill child to major hospitals, as they would naturally incur huge expenses depending on the child's condition. Of course, there are charity or public hospitals around, but a number of them, at least in the Philippines, still charge the family a percentage of the total bill after subtracting the national health insurance benefits. In spite of these, PICUs in low middle income countries in the region have continued to grow and expand in their own ways in an effort to improve the care of their nation's critically ill children. Although history is still unclear as to which US hospital can lay claim to being the first to put up a PICU, with Children's Hospital of Philadelphia often being credited, according to my own research, the development of pediatric critical care in Asia began in Japan with the pediatric anesthesia training of Doctors Seizo Iwai and Hiroshi Sankawa in 1965 under Dr. M. Digby Lay, a well-known pediatric anesthesiologist and author of Lay and Belton's Pediatric Anesthesia book. Doctors Iwai and Sankawa participated in the development of the J circuit in the bird ventilator, aside from other major achievements. It was only years later, in the early 1970s, that other noted Japanese physicians trained to become pediatric intensivists, who then eventually established pediatric critical care as a specialty in 1977. Other countries eventually followed. In China, Professor Fan Xunmei of Beijing Children's Hospital was credited as the pioneer pediatric intensivist who, with the assistance of the WHO in 1983, set up the first PICU with only 6 beds and 1 ventilator. From then on, a number of master's and doctoral degree programs were established, and foreign training in pediatric critical care medicine was encouraged, thus producing specialists to man the PICUs being built all over the country. In the Philippines, Dr. Herminia Cifra, who took her pediatric critical care fellowship training in Australia, was credited as the pioneer pediatric critical care medicine specialist who put up the first and eventually the largest pediatric ICU in the early 1980s in what is now known as the Philippine Children's Medical Center in Quezon City. Fellowship training began later that decade, and their almost 50 graduates are currently fielded to different parts of the country. At around the same time, the 8-bed pediatric ICU of the Philippine General Hospital was inaugurated. Later on, an intermediate care unit was established to support the growing number of patients who needed close monitoring without the critical care requirements. These units were initially manned by 6 pediatricians, including a neonatologist. Medical equipment was acquired only through numerous fundraising projects. Eventually, a fellowship training program was began in 1990, producing around 20 graduates to date. Similarly, the University of Santo Tomas in Manila encouraged its hospital staff to undergo further training abroad. This prompted Dr. Maria Luisa Uson Peralta to go into pediatric ICU fellowship training at the University of Hong Kong and, upon returning, established the UST Hospital's 3-bed pediatric ICU in 1987 with only 2 pressure ventilators, a couple of syringe pumps, and cardiac monitors. This would later be expanded to its present 10-bed capacity with a full complement of ventilators, cardiac monitors, and other essential equipment. Fellowship training began in 1998, and to date, they have produced almost 30 pediatric intensivists, also spread out all over the Philippines. The 1990s saw the establishment of PICUs in other countries in the region. In 1991, India put up the first organized PICU at the Kanchi Kamakoti Child's Trust Hospital in Chennai, India. With 7 beds, a dedicated team of doctors and nurses, and a pediatric anesthesiologist as the director of the unit. The other pioneering institutions were PGI MER Chandigarh, Sir Ganga Ram Hospital in Delhi, and Hinduja Hospital in Mumbai. In the years that followed, the growth of critical care medicine, as in most countries, was secondary to the development of adult critical care medicine. Early on, most of the pioneering pediatric intensivists went abroad for training. Consequently, by the 2000s, formal fellowship training programs were developed. And with the support of the Indian Academy of Pediatrics, this has grown into 22 accredited centers, graduating more than 250 students as of 2018. Eventually, from the late 1990s, Pakistan, Malaysia, and South Korea introduced pediatric critical care medicine into their respective hospitals. As in high-income countries and other low-middle-income countries, adult critical care medicine was first to be established. Initially, there were no dedicated PICUs and staff. Pediatric patients who needed ICU care were housed in adult ICUs and cared for by general pediatricians and adult-trained ICU nurses and staff. When pediatricians came back from fellowship training abroad, they each brought their knowledge and training back to their home countries and were credited in eventually putting up their own PICUs. Naturally, at the start, these were manned only by themselves, with occasional support from general pediatricians and the general nursing staff. Eventually, with the support of the administration, dedicated PICUs were set up, equipment was supplied, and nurses and other healthcare staff were trained. In summary, the practice of pediatric critical care medicine in low-middle-income countries is effectively still in its infancy. To paraphrase Ram Emanuel, we have come a long way from the early days of each country having only a few practitioners with limited equipment and untrained staff, and we still have a little further to go. Nonetheless, I firmly believe that with a little bit of sweat and a lot of heart, we will eventually catch up with our Western neighbors, if not within the decade, hopefully the next. Challenge accepted. These are my references and the images I used. Maraming salamat po.
Hello everyone, I am Dr. Millennium. I am a pediatric intensivist from India and a member of the World PICU Awareness Week Committee 2021. First of all, I would like to thank the World Federation of Pediatric Intensive and Critical Care Societies for giving me this opportunity to interact with you all and speak upon the current state and scope of pediatric critical care medicine training in Asia. If we look at the history of pediatric critical care medicine in Asia, it started as a separate specialty of medicine in early 1980s to 1990s. In Japan, China, and India, it started almost simultaneously as a separate specialty. In India, in 1990, there were only about 4 pediatric intensive care units in the whole country. But currently, there are about 70 to 80 pediatric critical care medicine training centers in the whole country, with more than 1,500 pediatric intensivists enrolled under the intensive care chapter of Indian Academy of Pediatrics. In Singapore and Malaysia, pediatric critical care medicine training is being conducted as a separate specialty and program under the Ministry of Health since last 2 to 3 decades. Whereas in other countries like Pakistan, Bangladesh, Nepal, Sri Lanka, Philippines, and South Korea, it is still in early stages of development as a specialty. So where are we currently in terms of the pediatric critical care medicine training in Asia? So in the last 2 to 3 decades, we have developed well-structured training programs and training centers in our region, but they're still limited to just 3 to 4 countries and very few centers in each country. If you look at India, which has a population of 1.3 billion people and 25% of its population being less than 18 years of age, there are only around 70 to 80 pediatric critical care medicine trainings in the whole country, with almost the same number of intensivists graduating every year, which itself tells us about the wide gap and requirement of more and more pediatric intensivists in the country. Although there are many state-of-the-art PICUs and state-of-the-art transport facilities for sick children in Asia, they're again limited to big cities and metropolitan cities and not accessible to a huge population in the region. We have embraced newer technologies and equipment in our ICUs, but very few centers in Asia are at par with the Western world and Western PICUs. There has been a widespread use of simulation as a training tool in pediatric critical care medicine in the last few years, thanks to Pedistars India's Simulation Society in India, which has been conducting many workshops and boot camps for the PICU trainees in India and the neighboring countries since last couple of years. Also, there is a huge development in the terms of research in our region, and a lot of centers are collaborating for research, and new original research papers are being published from Asia, thanks to one such collaboration like Pacu in Asia. So this is the Asian PCCM group at the WFPICS conference 2014 at Istanbul. So what is the scope and need of pediatric critical care medicine training in Asia? South Asia is a home to about 627 million children under 18 years of age, which is approximately 36% of its total population. The world has made remarkable progress in child survival in the past 2 to 3 decades. Only 1 in 27 children died before reaching the age of 5 years in 2019, as compared to 1 in 11 children in 1990. But still in 2019, almost 6.1 million children and young adolescents died, which were mostly preventable. And within many developing countries, inequality in child health outcomes still remains vast, and most of the care of seriously ill children in these countries is provided by general nurses and non-specialist doctors who are not trained in the care of sick children in our region. In developing and transitional countries, pediatric intensivists have the potential to improve the management of seriously ill children throughout their country by training the staff in smaller hospitals, by encouraging the building of effective emergency healthcare systems for children, and also by providing high quality clinical care in tertiary care settings wherever there are PICUs. As we all know, in our region, rural district and small provincial hospitals play essential roles in preventing child morbidity and mortality. It has been estimated that well-run district hospitals may prevent up to 44% of child deaths, which could have otherwise happened in their absence. Yet, in developing countries, these hospitals are generally understaffed, under-resourced, and have little or no ongoing staff education for management of sick children. And again, sick children are cared for by general nurses and non-specialist doctors who are not trained specifically in caring sick children in these ICUs or hospitals. So in many of the developing countries and in our region, serious childhood illness is a major economic burden on many families, especially if the care of their child is provided away from the community. The need to cease work and payment for transport, admission, and prolonged treatment costs can lead to a cycle of poverty and poor health that affects the entire family. Therefore, many health experts have suggested a minimum level of care that, based on the nation's resources, must be available for all children in accordance with the principle of distributive justice. In India, for example, oxygen, IV access, fluid resuscitation, antibiotics, and non-invasive application of CPAP in clean environment have been considered as the minimum level of intensive care support that should be made available to all children. Therefore, to maintain standard of quality in the PICUs and to improve the care of sick children, it is very important that we have adequate training and certification of intensivists, nurses, and residents. And there is good administration and supervision of these services. And we develop newer protocols for the management of sick children and keep upgrading our equipment and technology. It is also important to stress upon the need for freely available transportation, without which pediatric intensive care will not fulfill the principle of equality because it will not be accessible to a large population. Moreover, children from remote areas may die in transit as their families may attempt to make their own ways to hospitals and ICUs with sick children. Therefore, I would like to say research, innovations, and training in pediatric critical care medicine in developing countries, focusing on simpler, safer, and cheaper technology are much needed, which have the potential to influence the way pediatric intensive care medicine is practiced worldwide. We all should work towards achieving the Sustainable Development Goals as called by the UNICEF, which requires a global shift from just treating the diseases to strengthening our healthcare systems so that all children and adolescents, along with the women of reproductive age, have access to affordable and quality health care. So with this, I would once again like to thank the World Federation and would like to say that every child has a right to survive and thrive, and we all should make our efforts towards that. Thank you very much.
Hello everyone, I am Deepika. I am the PSU nurse in charge at Rainbow Children's Hospital, Bangalore, India. It brings me immense pleasure and pride to get this opportunity to work, collaborate, propagate awareness about the PSU nursing status in the region of Asia. It is indeed a rare opportunity to be involved in this initiative by World Federation of Pediatric Intensive and Critical Care Societies, being a PSU nurse representing not only India, but the Asian community nursing staff. Now, let's move into our topic, development in PSU nursing in Asia. Remarkable changes have occurred in the field of pediatric intensive care nursing in recent years, due to the needs of the society, medical and technological advancement. Need of critically ill children are unique and highly specialized. Overall, the field of pediatric intensive care nursing has grown its leaps and bounds in past decade, and there has been a tremendous increase in the number, efficiency, and knowledge of PSU nurses all over the region. Despite which, still we have a gap in sufficiently trained and qualified PSU nurses in available units. this gap is more wider in rural and urban areas. Present state of PICU nursing in Asia. If we see present state of PICU nursing in Asia, there is a wide gap in the ratio of PICUs and the number of specialist nurses in Asian PICUs. This is mainly because essential PICU training is unavailable or it is out of reach for many of nursing colleagues, and there is lack of awareness for the need of PICU training. Overall, in the region, we still feel that there is a deficiency in qualified nurses and sufficiently equipped PICUs in the region. This may be because there are not specialized courses addressing PICU and NSU curriculum. To that end, in India, many of the recognized institutions formally introduce some of the courses like Advanced Nurse Practitioner, Fellowship Program, Advanced Diploma, etc. in the region, and similar courses available rest of the region. With this, we might see gap getting narrowed next few years. I may also suggest to incentivize the specialist nurses. This will encourage more number of nurses to take up with specialty courses. Need for training in PICU for nurses in Asia. We need training because of ever-growing technological and medical advancement in the region of PICUs. Working in intensive care is a stressful job, and it is more tougher if the patient is child who is not able to express his or her problems clearly. They also need constant medical as well as emotional support that can be quite draining on the nurses. Intensive care nurses need psychological support as well function effectively in such an environment. Throughout the region, we have dedicated support systems to provide such support. Like for example, Associates Care and Assistance Program in Philippines, etc. Even then, we have noticed tremendous burnout among the PICU nursing fraternity with significant amount of attrition. We think that there may be more widespread need of support system looking into the emotional and psychological aspects of nursing care locally as well as nationally in all the countries. Therefore, I stress upon a point that working in PICU or working some days in children's hospital is not enough to become a PICU nurse. Having only pediatric intensivists without enough trained PICU nurses are not sufficient in building an efficient healthcare system caring for sick children. Therefore, I urge policymakers to improve the infrastructure for training in pediatric intensive care nursing, and I request my fellow nursing colleagues to make it a career option and help in creating a better healthcare system for sick children who are the building blocks of our nation. And I would thank World Federation of Pediatric Intensive and Critical Care Societies giving me this opportunity, and thank you all.
Hello and welcome. I'm Dr. Sidra Isaac, and I'm working as an assistant professor in the Department of Pediatrics and Child Health. And it's a great opportunity for me to present on some of the challenges and priorities for the pediatric critical care physician in the LMICs. And I'm very thankful to the World Federation for giving us this opportunity to share some of our ideas and the way forward. So the United Nations established Millennium Development Goal that was aimed to reduce the under 5 mortality rate by 2/3 between 1990 and 2015 as part of the United Nations Millennium Declaration. However, we are all well aware that the highest rates of childhood deaths are concentrated primarily in the lower and the middle income countries. And an important area of focus here is the health disparity. That is the 1090 gap when we talk of all of this. That is only 10% of the world's resources are basically concentrated towards healthcare of the 90% world's poor population in the LMICs. And I think this is a very, very significant factor when we talk about healthcare disparities and the challenges that we as pediatric critical care physicians face in the lower middle income countries. So all that is required is a simple resuscitative and critical care interventions. And if we could work towards those in order to improve our healthcare outcomes, but it's not so simple as it says here. There's just so much that we need to do, and there's just so much that is required basically in order to work towards all of this. Then there's also a need to work towards pediatric critical care resources. And I'll be talking of like some of the important areas that we could possibly, work towards together in order to improve the healthcare outcomes. There's need for the LMIC institutions and researchers to conduct critical care research according to local resources and disease spectra. I'll take this moment to mention Dr. Paul Farmer's 4S components model. And I bring this up here because he is a global authority on health equity, especially, and he's actually dedicated his life in order to improve outcomes in resource-limited settings. And he very beautifully elaborates on the components that we could actually work on while we're talking about our challenges and our priorities. So the 4 important S components include staff. That should include properly trained and compensated healthcare professionals. Stuff, that is appropriate medical equipment. We talk about space, that's a clean environment to treat our patients. And of course, the systems looking at it holistically to provide the infrastructure and logistical organization to provide the services. And I will next move on to discuss the challenges that we as critical care physicians or people working in the LMIC settings actually face. So some of the obstacles to establishing critical care nursing include lack of funding for specialized training. And this is a very important factor because we do not have any established curriculum for the nursing staff here. And I think this is the need of the hour, that if we could actually come up with some curriculum or some education that could be actually standardized across the globe, or at least amongst the LMICs, if we could actually work towards that. So that is probably one of the greater challenges. Inability to provide adequate staffing for ICU nurse to patient ratios. And of course, if we look at the COVID situation, so nobody else would know better than us how we've actually managed doing this. Traditional role of nurses in the hospital, including level of education, experience in critical care, cultural norms, and comfort surrounding communication with and respectfully challenging a physician's orders. Inadequate compensation to encourage retention. This is important, and there's enough data to suggest that with all of the staff trained because of inadequate compensation and how badly that impacts the patient outcomes with, especially in a resource-limited setting. Then allowing nurses who are fully trained and invested to be allowed to remain in the pediatric intensive care units without frequent rotation and reassignments. This is very important. And of course, there's a need for well-trained nurses to work as preceptors and mentors to new staff. And that can only happen once we have enough retention, once we have an established curriculum, once we have enough incentivization for our nurses, and especially the well-trained senior nurses who could then actually act as role models and mentors to the new staff and make it a different ballgame altogether. Moving on next to the research challenges, and this is probably one of the biggest challenges that we as clinician researchers face in the LMIC. And what tops the list is, of course, the lack of funding. There's high clinical burden for sure. We have huge data, we have rich data that we could actually contribute to. But of course, with that, comes the lack of research resource staff, the lack of statistical support, finding research mentors. That is very, very important, because whenever we talk about, collaborating internationally or collaborating at a global level, so of course, it's very hard for us, to find local mentors in our setting, who would actually guide us through this. And of course, the difficulty with publications is a very common phenomenon too. So some of the research solutions that we thought, we could present were to allocate more funding for the low resource settings. Access to mentors in the HIC. I think this is a very, very important factor that we physicians in the LMICs could actually look forward to. And this would not only help us, guide through the process of research in itself, but of course, would actually bring about a lot of thought sharing, a lot of data that we could probably utilize in order to improve our patient outcomes. And we may actually get a lot of way forward from the mentorship from the global leads in the HIC. Access to research training and networks, research collaborations, opportunities to present globally, protected research time, and of course, HIC research collaborations are some of the research solutions that we have to offer. So all of these challenges and potential solutions shall actually help generate data that improve clinical care, would ensure quality and safety, and establish guidelines to standardize care, shall help foster opportunities for research collaborations, and shall help peer recognition and of course career advancement. Moving on next to challenges in education that we face in the LMIC. Well, there's a substantial variation in duration, content, and assessment. So not just at the nursing level, as I've already mentioned earlier, there's a huge variation in the content when it comes to training our trainees also. So there's no one standardized approach to how we actually take the curriculum, especially in a resource limited setting. There's lack of a gold standard in training that makes the design of a critical care curriculum much more complicated. So some of the solutions, or some of the possible solutions, as I would label it, would be, attempting at creation of a pediatric critical care training program through an international collaboration, if that is possible. Maybe critical care training can be further leveraged through visiting temporary trainers from resource-rich countries in order to see how our setups are, and then we could take it forward from there. Critical care training can also, be supported by supporting clinicians in the LMICs to train abroad and, bring in ideas from there. And of course, what we don't get to see in practice here. So this again, may be a greater incentive to look forward to. Then use of free online resources, e.g. the Open Pediatrics, that's a huge resource for the LMIC especially. And we talk about the Pediatric Fundamental Critical Care Support that has a standardized curriculum, especially for the novice critical care trainee, be it a staff or a physician. So that is one of the resources, that can be utilized. And of course, teaching through simulation is one of the potential solutions as well. So as we talk about skills in caring for critically ill children, and as they get established, we propose, and I suggest, that there has to be a parallel set of skills in teamwork and leadership also are essential in the development of a pediatric critical care program, when we look at it broadly. And therefore, some of the future prospects would include development of training and capacity building programs, a stepwise introduction of service improvements, leveraging human resources through training. And training has to be a major focus. There has to be focus on sustainable technology, ongoing analysis of cost effectiveness, and the sharing of context-specific best practices. Expanding on train the trainer programs, and that is one of the ways that we can actually expand onto our curriculum and expand onto greater collaborations, greater utilization of newer technologies, e.g. the AI or simulation, in order to help standardize the curriculum, and of course the use of point-of-care diagnostic devices in resource-limited setting. And I would like to end here by saying that LMIC physicians must be better encouraged, empowered, and equipped to lead local and global platforms to improve patient outcomes for critically ill children. And we look forward to support and greater collaborations from the HIC. Thank you once again, and I'll be happy to take any questions.
Good morning, good afternoon, good evening, everybody who's listening to this talk. I am Dr. Kalbi Abbas, a pediatric critical care physician at the Afghan University, Karachi, Pakistan. I would like to thank WebPix for providing me this opportunity to talk at the occasion of World PICU Awareness Week on the impact that the pediatric critical care is creating or can have in the LMIC, and what are the potential opportunities. So I'll just touch upon how the critical care medicine evolved over the passage of time in last 100 years or so. So it all started in 1850s with the Florence Nightingale, which separated the area for patients who required some more intensive monitoring. So it all started with that idea of monitoring. And then Dr. Walter Dandy came up with the idea of a specialized post-operative care unit establishment in 1947, specifically for the neurosurgical patient, and that was followed by more specified and specific unit establishment during the era of World War II for the post-operative patient, as well as the establishment of shock unit. This era was called the Florence and Florence Nightingale era, and this was followed by creation of more specialized post-operative care areas, as well as the creation of tracheostomies and areas where the patients with tracheostomies were taken care of. And then this kick-started a new era in the critical care medicine with the polio epidemic in the 1950s. And that led to the more evolution of critical care medicine, where a first acclaimed ICU was made in Sweden in 1954. Then Dr. Peter Safar led to the most specific and more complex care in the United States, and that was followed by rapid growth of modern ICUs. And in 1970, with the formation of this new cadre of physician, the Society of Critical Care Medicine was formed. So pediatric critical care lagged a bit behind. From 1930 to 1950, it was the adult physician who used to look after the pediatric patients. Then as the neonatology field developed, there were more and more preterm neonates who continued to survive. They continued to develop bronchopulmonary dysplasia, and then there was a need for extended care. At the same time, the first post-surgical area for infants was designed, and at the same time, congenital heart surgery started. It took its birth, and this required a specific areas as well as specific physicians who could take care of these patients, and all this then lead to the development of a subspecialty of pediatrics called the pediatric critical care medicine, and it was recognized in 1947. So this all happened in the developed world, while the evolution of critical care medicine in LMIC is not well documented. But I think that it's important to discuss this because the major burden of the critical illness lies in these countries, and the majority of the population lives in these countries. So initially, WHO came up with Millennium Development Goals, and the goal number 4 emphasized to reduce the under 5 mortality by 2/3 by 2015. And they mainly emphasize the intervention to be based in the public health and as well as in the ambulatory setting, while the acute and hospital care wasn't that emphasized, and it did not improve. And while later on the WHO worked on this, and they developed ETAT, IMCI, and then they also published a book for the care of hospitalized children. So if we see the need for PCCM, so there are 3 fundamental functions of a healthcare system, and these include to improve the health of population, to respond to the people's expectation from a health system, and to protect or provide the financial protection against the cost of ill health. And critical care is a field which can contribute to all these. And there is data to show that if you improve the responsiveness of the healthcare system to the people's expectation, their uptake of different intervention improves, their uptake from the health system improves, and that leads to better outcome, because this is one of the major challenges, that people don't come to seek care or at the right time. And this is one of the 3 delays that happen in LMIC. And this is just one of the example of a paper published in Lancet in 2001, that even with the implementation of public health intervention along with IMCI and the primary health care, there are almost 1/3 of the children who require hospitalization and acute care. And around 90% of these children have one of those 5-6 common problems which are very amenable to treatment and management. So this is just a slide that compares the overall under 5 mortality in different countries and its relationship with the gross national income capita. So you can see the major couple of countries who contribute to the major world population is India, Pakistan, Bangladesh, along with China. And being in the same region, there is so much diversity in the, though there is no so much difference in the gross national income per capita, but there is a difference between in the under 5 mortality. And the same is true for Sri Lanka. You can see it's in the same region, but comes at a different point in this graph. And the same is for Cuba and United States. And if you study the healthcare system of these countries, you will come to know that their public health as well as their tertiary care facilities as well as complex care for pediatrics is more or less similar, irrespective of what their economies are like. So this emphasizes the need that with pediatric critical care services, you can certainly dent the under 5 mortality, which is a major problem in low and middle income countries. So WHO says that one of the major killer of children, the common final pathway of all these diseases which are killing children in the LMIC is sepsis. And in developing as well as in the developed world, the provision of critical care services can certainly reduce mortality in both of these parts of the world, as well as it has been shown to have an impact in the high income countries. So this is the trend of under 5 mortality in from 1990 to 2019 in the last 3 decades. So you can see that in India, Iran, Pakistan, Ghana, and Indonesia, Pakistan is one of those countries which hasn't fared well as compared to other countries. And one of the reasons is that pediatric critical care is still at its very infancy. In a survey done by our group showed that there were only 16 PICUs in the whole country, and the acute care services are very limited in majority of the country. So, and if you see the causes of under 5 mortality in Pakistan, it shows that the majority are pneumonia, diarrhea, prematurity, sepsis, measles, and injuries. And the UNICEF data shows that 158 children die per day just because of pneumonia. And this is one of those diseases which can be easily catered by good monitoring, provision of oxygen, and timely antibiotics, as well as sometimes respiratory support. So this is another study that was published in Lancet, and that showed that critical care impact can be huge in the low and middle income countries as compared to in high income countries, shown by these graph, where the blue bar shows the total death from condition that would potentially benefit from availability of critical care. So you can see the bar in the low and middle income countries as compared to high and upper middle income countries, while the red bar shows the percentage of all that would potentially benefit from the availability of critical care. So it keeps on increasing from the high income to the low income countries. So this is just a list of comparison of some of the conditions in pediatrics which can certainly benefit from pediatric critical care in the low resource setting. And these are the conditions which are the major determinant of under 5 mortality and pediatric mortalities. While these conditions have been shown to be have a long-term bad prognosis. So maybe we can certainly put our efforts to treat these diseases with the pediatric critical care, and this can certainly then have a significant reduce the mortality. And this pyramid just shows that how we can improve the how we can target the low-hanging fruit and improve interventions in low and middle income countries which have a child mortality of greater than 30 per 1,000 children. And you can see that simple interventions of immunization and public health intervention, along with IV fluids, antibiotic, CPAP, oxygen, and first hour antibiotic, fluid resuscitation, inotropes. So these are the basic crux of ICU intervention. If you can make them available, the mortality reduces and these are all the studies which have been done in different settings to show that the mortality significantly decreases. So what are the solution and what are the opportunities and the building blocks? So I have divided it into three. This is how I see that we can improve the critical care and where we have the opportunities. And you can see that research is one thing which continues to have a long-term impact. So we need to improve the research infrastructure as well as research capacity building in healthcare providers who are providing acute and critical care in LMIC. So number one thing is working with the capacity building to improve the knowledge and skill of healthcare providers through short focused courses and workshops, using simulation, using technology, and this can be done in a tele way. Then the need for long-term mentorship and continuous evaluation and monitoring of these interventions is important. And I have just highlighted a couple of examples which we did in Pakistan with a good reception for the training of mechanical ventilation and the basic principles of pediatric critical care. Then clinical service improvement, and you can improve the clinical service improvement by improving the infrastructure to have the assessment and then need assessment, and then followed by the development of infrastructure, then development of local protocols and pathways, and then providing ongoing support to different facilities through tele-ICU. And this tele-ICU can be a tele-monitoring, this can be a tele-mentoring, this can be a tele-QI thing. And then there is a concept of task shifting that you, through this tele-monitoring and tele-ICU support, you can increase the capacity of healthcare providers who are working in remote areas by providing them support from a distant area. And then long-term partnership and sustainability with all these facilities is important. And this involves monitoring and evaluation. Impact analysis is very important. And then development of leadership and mentorship, and then local empowerment like train the trainers concept. So thank you very much again for providing me this opportunity, and let's work together to for the betterment of children in LMIC as well as all over the world. God bless you, and thank you very much.
Hello, my name is Wajin Cho, a pediatric intensivist from South Korea. Today my talk will be about research in PICU. We all know current evidence in pediatric critical care is not enough. So to improve the outcome, we need to investigate clinical practice and mechanism in various course of diseases. Both clinical and basic research can provide evidence in various levels, which can change our preventive and therapeutic interventions, and all these can improve our outcome and cares for critically ill children. So my talk will touch a little bit on current PICU status in Asia and published papers from Asia with most cited papers. Also, I'll touch a little bit on ongoing RCTs from Asia and basic research, and we'll conclude the talk. So first is about the PICU status in Asia. Asia is a huge part of the world, and there is 48 countries in Asia, while 193 countries are in all over the world, which is about 1/4 of the numbers. And this gives us some sense how variable cultures and practice in pediatric critical care might exist in Asia. The numbers of languages are even more various. It says more than 4.3 billion people are speaking nearly 2,300 living languages across the Asia. And this is not an exaggeration, and there must be some language difficulties in collaborating internationally. When we look a little deeper about critical care bed in Asia, there is an article published in CCM last year, and here you can see the numbers of ICU beds per 1 million population. Again, the numbers are extremely various. For example, Japan, Taiwan, Hong Kong, Singapore have relatively bigger number of ICU beds, about 6 or 7 beds per 1 million, while some high-income countries have only 2 beds. In Kazakhstan has 21 beds for 1 million. So the numbers are really variable. How about the PICU beds? I don't think we have published data for PICU beds only yet. This is an unofficial data from PACMAN collaborators, which I received from John Howe, and some other data I collected personally. Again, the numbers of PICU beds are variable. For example, in Korea, it varies from 5 to 25 beds, and in China, the numbers vary from 8 to 41. The reason I'm showing these maps are to show how difficult PICU research in Asia can be. Other than general barriers such as high clinical intensity and less time for research, Asia might have country variations and center variations in practice, and of course have some language difficulties in collaboration. But we all know someone tried to overcome these issues and created an Asian collaboration group named PACMAN. And actually, they are publishing papers and running many papers, which is very, very encouraging. Next is published papers in Asia. I searched in PubMed on March 1st, 2021 by the keyword of pediatric intensive care. In overall, the numbers of papers are exponentially growing. And when we look into the papers in 2020 only, the total published number of papers were 778. And 22%, which is 172 out of 778 studies, were from Asia. And I myself did not know such many papers were published in Asia. And I thought this result was again very encouraging. I also have searched papers published in PCCM for the last 5 years. And during this time period, the total number of published articles in PCCM was about 1,500. And among these top 10% cited article, which is about 150, 9 articles were from Asia. And these papers are top 10% cited papers. And congratulations to all authors. We know how important RCTs are. First, I was curious whether any of RCTs are going on in Asian countries in the field of PICU, and if any, how many RCTs and which topic of RCTs were going on. I have searched clinical trials with the keywords of pediatric critical care on March 31st, 2021, and found 132 RCTs currently ongoing. Among these RCTs, 12 studies were from Asian countries. And while 10 studies were running only in Asian countries, 2 RCTs were collaborating with Asian countries. So I am really looking forward to their work in the near future. I was again very curious what kind of basic research is going on in Asian country in the field of pediatric critical care. I myself am doing basic research on the theme of ECMO since 2013 with various animals, pigs, dogs, rats. The topic of adjunctive therapy with ECMO and ECMO model development in small animals and ECMO applicants in disease models and looking for pathophysiologies and hopefully looking for some evidence which can influence our clinical practice. As you all know, other than network or collaboration, research needs time and efforts and money. I could not run a survey for this, but I am again very curious. Please give me feedbacks after this talk. Whether you have dedicated time for research in your country or in your center, free from clinical work. The answer for me is no. I don't have dedicated time for the research. I have to spend my own time after my work. And also, how are funding opportunities in your country for clinical or basic research? I was lucky to have continuous funding since 2017, but it was not always easy. I had to spend my own money from my own pocket until I get some stable results. So I'll stop here and conclude. Research in PICU is challenging, as many things should be considered and should be interactively connected. We all are willing to have quality research where every PICU patient benefits directly or indirectly, and which can inform clinical care and which can lead to future research. And I really wish many quality research from Asian countries impact our practice in the near future. Thank you.
Hello everyone, this is Dr. Rakshay Shetty. Greetings from Bangalore, India. I work as a pediatric intensive care physician, and I'm going to talk for 10 to 12 minutes on the future perspectives of pediatric critical care medicine in Asia with very specific reference to LMIC countries. This is a place where I work. That's in the southern part of India, and we have a 24-bed tertiary care pediatric intensive care services. So why is it the intensive care services in LMIC countries important? Because as of 2018, nearly 5 million children have died before their 5th birthday. And 1/3 of this unfortunately comes from southeastern countries of Asia. Now, as per the sustainable development goals, the goal is to reduce under 5 mortality to as low as 25 per 1,000 live births by year 2030. Now, we know that a significant burden of under 5 mortality comes from LMIC countries, specifically in Asia. And what we also know is a lot of these unfortunate deaths happen from simple illnesses like poor management of pneumonia, diarrhea, encephalitis, and coupled with malnutrition. And looking at these conditions, and it's quite apparent that 20% of these children would actually need intensive care services. So by strengthening intensive care services, we can have a significant impact at the community level. So if you were to look into why is it these children die, I mean, there are at least 3 common patterns. One is a delay in recognition of this condition, delay in seeking care, and delay in reaching appropriate healthcare facilities. And in most instances, there might not be an appropriate healthcare facility for a sick child. So let's look at this problem because clearly there is a limitation in terms of availability of intensive care beds. Now, the information in Asian countries, especially LMS countries, it's quite limited with available data, but it is clearly inadequate compared to developing nations. So in developing country, it can be anywhere from 5 to 30 per 1 lakh people, but that falls short of short to 0.1 to 2.5 beds for 1,000 people in LMIC countries. And also, unfortunately, what happens is the public healthcare spending is very low when it comes to tertiary care ICU. And oftentimes, this is compensated by the private hospitals. And oftentimes, there are private hospitals which have developed to a wonderful degree in terms of providing services equivalent to developed countries. But there are also various hospitals which provide very variable care and sometimes poor quality care. And also, this is not an uncommon situation. I've just taken an example of dengue epidemic. That is something which we see every year, almost every year. And oftentimes we see patients just hopping from hospital to hospital to find a bed and in the process lose life. Now, one of the very, apart from shortage of beds, the other very painful factor in LMIC countries is the cost of critical care. Now, this is a very nice report which has come from Vietnam. And if you look at the report, the expense looks very low. I mean, it's just around $28 per day in Vietnam, which obviously is very, very low compared to what we see in a developed nation. But unfortunately, what happens though is when it compared to per capita income, this is still very high for people. And oftentimes, the media and the public just go all over critical care services, become very upset, say that the expense is too much. And then it puts a lot of burden on healthcare workers who specifically work in critical care areas. So why is it expensive? Now, the problem here is in LMIC countries, that many of these equipments are not locally produced. So they need to be imported. And unfortunately, the import duties are very heavy. And it makes actually owning an equipment in a LMIC country, the medical equipment is far more expensive than a developed country. And that's a paradox, unfortunate paradox. And also there's no competitive market for these makers to bring down their costs. In addition to that, the high-end laboratory equipments, these also need to be imported. They're quite expensive. And you also need a highly trained staff to run those labs. In addition to this, there are issues with poor service, lack of replacement parts, frequent power cuts. It leads to damaging of these equipments. In addition, people really struggle to have a highly trained staff, especially nursing staff, to stay with them. And oftentimes they're compensated by newly trained out nurses. Oftentimes they're not skilled, and this leads to a lot of variation in the infection control practices and unacceptable complication rate. So what should we do? I mean, as a community who are looking at reaching at a grassroots level and help these children, I think the most important thing is to think about how do we provide timely emergency care for those living at a community level? How do we make tertiary care accessible and affordable? And also, what should the research priorities be in these countries? So I'm just going to talk very, very briefly on each of these topics. Just to give an overview about how we might have to think for future to stay relevant. One, I think it's very important not to build very expensive, difficult to maintain tertiary care services at community level. It's very important to focus on a level 1 ICUs or high dependency units, because we know, this is like pneumonia, this is like diarrhea, they just need simple basic intensive care services and significant impact can be done. So this is very important because for this to happen, it's very important that as societies, as the bodies like World Federation, like the national bodies, advocate at a national level in public health policy making. In fact, if you look at the success of newborn healthcare in many of these countries, it came from a mandate of decreasing newborn mortality rate. And often what has happened with that process is a lot of newborn units have been set up at a very small district and town levels. And that is something we need to also propose to the government to setting up not very expensive high dependency units in many of these setup. The second main issue comes with training, because setting up a unit is one, but how do we actually train? So there is some amount of work done by a lot of bodies across the country. Like for example, in India, we run these courses called as EPIC course, and there is PFC's course run by Society of Critical Care Medicine in America. There's also basic course. These are fantastic courses. But the issue with a lot of these courses though, is they're very heavily physician dependent, don't really take nurses into account. And oftentimes that becomes a limitation. So we can learn a few things from the newborn, how the newborn services went about extending their routes to district and small towns. So one of the things model developed was a mentorship model, identifying centers of excellence, and that is something we should do, and allowing those centers which want to develop their new intensive care services, SD or level 1, spend few months in the center of excellence, and then the mentor program, the mentors should visit those places frequently once a month for a year to help them setting up those services. And that is something we should look at. And there is a good experience coming out of developing those kind of newborn services, and they are quite encouraging. So let's come to this concept of how do we make tertiary care now accessible. We need to decrease now clearly the equipment costs and the laboratory costs. We need to address the manpower shortage, and we need to focus on ICU improvement, ICU quality care. So one of the interesting things which has come up in the COVID, especially is the use of tele-ICU. In fact, there are quite a few tele-ICU set up across India to facilitate providing tertiary care to patients who are very sick with COVID. And that is something we can actually leverage, because currently, though the number of trainees have increased over years, but the demand is so much. And because many of the intensivists who are being trained kind of set up and stay in cities, they don't go to rural levels, and there are no setups also. So I think tele-ICU is something we should look at. Adult people have taken that in a big way, and as a pediatric community, we should also think about providing tele-ICU services to all those hospitals which have decent ICU. Even for example, an adult ICU, help them to manage kids in a better fashion. And the other thing which is very interesting is the use of point of care devices. Many of us might be familiar with devices like iStat, and also as you can see with the point of care ultrasound machine, which has revolutionized bedside management of critically ill patients over last decade. Now the scope of point of care services is very wide, but the beauty of point of care services is that they can provide rapid diagnosis at a lesser cost, and essentially can bring down the use of manpower, because the current issue is managing expensive equipments, needing skilled people to manage those is a huge expense burden, and this can potentially bring down the manpower costs, easy to maintain equipments, rapid diagnosis, and it helps in patient management in a very fast, quick way. Now, COVID also has thrown up new challenges. With that, the country, in our country especially, it has motivated a lot of people to enter into building ventilators. A lot of engineering students, engineering medical colleges have come up with the really low-cost ventilators, which is an excellent news, because the ventilators do cost quite a lot, and building local ones and helping them to sustain locally, I think that is going to significantly bring down the cost of providing tertiary care to sick children. Now, other very interesting possibility is the use of artificial intelligence. And this is a nice article which has been published about how we can think about using AI in a resource limited setting. There are some very nice studies which are published into looking at how can AI predict someone with dengue fever about him landing critically unwell and needing ICU. There are also studies published about looking at predicting poor outcomes for sepsis. And these are of really interesting value to us, because oftentimes the public health setup is plagued with poor manpower, many times inexperienced healthcare physicians, and then we have nursing manpower which is very limited. So AI can actually help, because it can actually tell you, okay, out of 40 patients in ICU, which are those 5 or 10 who are likely to get sick overnight, and potentially can allocate your nursing staff and medical staff to those really ones who are likely to get sick. And also, with the emergence of data-driven decision making, it can also guide a lot of young doctors who are quite new into this profession to take right decisions and timely decisions at the bedside. So this is again a very exciting prospect. There's one thing which we also worked over last decade is about use of simulation at a point of care in the hospital, essentially looking at providing team training, looking at preparedness and the breaking of hierarchy, and coming up with a communication pattern which can be very effective and safe for the patients. And that is something I think a lot of us should look forward to, because we know it's a team game, and it's very important that we train our staff adequately to work in a team fashion. So with regards to research priorities, I mean, in India, for example, we started with, from probably around 19 RCTs in 1990s to around close to more than 200 RCTs published by now. So there's a significant amount of progress which has happened in terms of research. But however, I think what is very important is developing mutual collaboration. A multi-center collaborative research is the need of the hour. not only within the country, but also country which have shared interests. Like for example, dengue, countries like Vietnam, Philippines do suffer from same problems. So I think we should look at developing networks and coming up with solutions which are relevant to us. Unfortunately, what is happening right now is we're importing whatever Western guidelines and trying to fit in our setup. And oftentimes we know it doesn't work. And the challenges are completely different here. So we need to develop our own evidences and come up with guidelines which are relevant to us. Now, also what's going to happen, especially with the low middle income countries, is that we have an aspiring population, there are rich population, and with more and more premature children surviving, children with congenital heart disease surviving, genetic syndrome surviving, there will clearly be a need to develop a very high quality tertiary care units, which is bound to happen. And there are a lot of cardiac intensive care units already, and probably neuro intensive care units also going to come, considering there's a lot of neuro intensive care burden. So it's very important for us to think in terms of multi-professional care and a family-centered care in these centers. What is also very important is developing quality of care. And I think it's very important from that people as well as government should look at this, because there's so much of variability in the kind of quality care being provided. And the variation goes from private sector and also goes from public to private sector. So I think it's very important we collect epidemiological data, because it's important to know the burden of disease in our own community, because that can make us much more smarter in terms of healthcare policy development. Also, it's very important that we look at developing quality standards for PICUs, especially performance indicators, so that standard care is provided irrespective of whether you're in private setup or in a public healthcare setup. And it's very important also, I think we need to focus on efficiency, not just on mortality data. How do we utilize beds, especially in public healthcare setup, so that more and more children get benefited from providing timely services. So with this, I would conclude my talk. So I think it's very important for us to not to become very elite, but we need to reach out to community and make a significant impact in the community. For that to happen, we need to focus on developing SDU level 1 services in the peripheral healthcare setup. We need to look at capacity building by providing mentorship program. We need to think about utilizing tele-ICUs, point of care devices, and artificial intelligence to currently bridge the manpower issues. We need to look at local manufacturing to decrease equipment cost, and also look at how we can use AI to provide better care at the bedside. Collecting epidemiological data is very, very important, because that can make the healthcare spending much more smarter. And we need to really look at creating our own guidelines and use this epidemiological data to come up with research priorities for that particular country and focus on that, rather than just copying what everything Western world does. Also, it's very important to move from a very variable care to high quality care all the times. So let's together try to make quality critical care medicine available to everybody, to the masses, not just to the elite. With that, I would conclude my talk. Thank you very much for this opportunity.